Thank you very much. I'm really grateful to be able to present our work here on Bictegravir in human breast milk. So here are my disclosures. Current guidelines do support breastfeeding in women living with HIV in case they have reached viral suppression and if they have good adherence. Unfortunately, there's only limited data available on pharmacokinetics of antiretroviral drugs, and this is also the case for Bictegravir. And as these drugs, when co-formulated with TEF and FTC, has been approved for use during pregnancy, we do expect that it will be used often during this breastfeeding period as well. It's a single tablet regimen, has a good tolerability, so it actually is really attractive to use in this postpartum period. However, we do not have any or very limited information on the concentrations in breast milk. So we sought a way to determine the concentrations in breast milk. And we did so with this study I will present today. So what we did in order to acquire timely data on Bictegravir in breast milk is include healthy lactating women who are not living with HIV, and who are able and also willing to abstain from breastfeeding up to 4 days after study participation. And we chose to build in this safety period to a certain or to prevent unnecessary toxicity or exposure to the infants of our volunteers, as they would not have an indication themselves to use these drugs. And we assumed, or we hypothesized, that Bictegravir would transfer passively into breast milk. We assumed that 4 to 5 times the half-life in plasma would also suffice to have the breast milk cleared of this drug as well. Participation would be excluded if they were known to have a severe galactose intolerance, but also if they turned out to have an HIV infection at screening, or if they would have comorbidity or co-medication known to interfere with the pharmacokinetics of Bictegravir. So this was our study design. So we would take pre-dose samples, both plasma and breast milk, and then administer 1 dose of Bictegravir together with Emtricitabine and Tenofovir Alafenamide, and then take plasma samples, breast milk samples at certain time points. And breast milk would be collected using an electronic pump from both breasts, and then the samples would be gently mixed and freezed until further analysis. And the way we analyzed these samples was using LC-MS, and we used a validated assay in plasma and also another validated assay, especially for breast milk. And then we would use these concentrations to calculate pharmacokinetic parameters using non-compartmental analysis in Phoenix. So using these concentrations, we were able to calculate breast milk parameters, of which first one would be the breast milk to plasma ratio. And we used the area under the curve in both these matrices to calculate those. Then we would calculate the daily infant dose. And because the participants in our study were not exclusively breastfeeding, the volumes of breast milk they expressed differed along participants. So if you would calculate only with the volumes we had in these participants, we had a wide range of exposures. So we used an estimate of daily infant milk intake to estimate, worst case scenarios. So what would happen if an infant would be exclusively breastfed? And we used an estimated intake of 150 milliliters per kilogram per day. And also for the very young infants who drink more milk a day, we used 200 ml. And with that, we were able to calculate a relative infant dose, so the dose ingested by the infant correlated to the dose of the mother. And we also did that with an estimated intake of the 150 or the 200 mils per day. And of note, the relative infant dose below 10% is assumed to be safe. So the risk of toxicity is considered very low if this relative infant dose is below 10%. So on to the results. We included 12 participants with a median age of 33. And as you can see, they had a wide range of time they were postpartum along with the range of weight of their infants. And here you can see the concentrations in both plasma depicted in a dark gray on the top, and then breast milk in the light gray below. And mind you, this is a logarithmic scale, so you can see there's a big difference between concentrations measured in plasma and that in breast milk. And if you then look at the PK parameters in both plasma and breast milk, you can see that the area under the curve is way lower in breast milk compared to plasma. Same holds true for the maximum concentration. And you can see that Tmax and half-life is slightly lower in breast milk compared to plasma. Then on to the breast milk parameters. So first off, the breast milk to plasma ratio is very low, 0.009. And then for the daily infant dose calculated with the volumes of breast milk we saw in our own participants and then extrapolated to our scenarios. And you can see that this daily infant dose is also low. And then on to the relative infant dose. Well, also here it depends on what volume the infant would take in, but it's still very low. As we saw that below 10% is considered safe. Well, in all scenarios, we're below 1%. So we saw that the transfer of breast milk, of Bictegravir in breast milk is minimal, and the relative infant dose is below the safety threshold. Well, it is a single dose study, so the concentrations we measured were not yet in steady state. But as we know that the accumulation ratio of Bictegravir is 1.54, I do not expect that after, when you reach steady state, toxic levels will be reached in breast milk. And also we know that the metabolic enzymes of infants are not yet fully developed, but still with these low concentrations, I think it's very, very unlikely that toxic levels will be reached. So that's for efficacy, for safety, the risk of toxicity in the infant. But if we look at efficacy, it's really difficult to say something about concentrations in breast milk and if they could be protective in the theoretical case that there would be transmission, as we know that if the mother is virologically suppressed, is good adherent, that the risk of transmission is actually really low. But we did see that the breast milk concentrations are below the protein-adjusted IC95. So there is a theoretical risk of development of resistance. But I think we only support breastfeeding in the case of virologic suppression and good adherence. So I think this is more a theoretical issue than something to really take into account. And let's look at Bictegravir in context to the other antiretrovirals that we do have data on in breast milk. You can see that it's actually quite comparable to other integrase inhibitor like dolutegravir with low breast milk to plasma ratio. And if you also look at the relative infant dose, then it's also comparable to the other integrase inhibitors and the other classes. So I think one of the limitations of this study, next to being a single dose study, is that we did not only include exclusively breastfeeding women. So that's why we needed to do the extra estimations. But this is a recognized method to estimate infant exposure. And it would not be feasible to include women that were only exclusively breastfeeding. To abstain from breastfeeding for such a long period of time. And I think one of the strengths of this study is that it allows for timely acquisition of such data in comparison to more opportunistic designs. So I hope that you will remember after my talk that the transfer of Bictegravir into breast milk is minimal and is not expected to cause any infant toxicity. And as it is approved during pregnancy, I think that this study supports the use during breastfeeding as well. And that this method using healthy volunteers allows for timely acquisition of PK data in breast milk. So thanks to all the participants in this study, my supervisors and everyone who supported this study and me personally. So thank you very much.